Here are some symptoms that can make dying hard. Dying isn't necessarily painful or hard, but there are certain symptoms that can happen at the end of life that can make it more difficult. So here are these certain symptoms, what diseases usually cause them, and how can we help? But before we get into that, here's a story that's a great example of this. Many, many years ago, I had a young woman come onto service. She had a brain tumor, which brain tumors can be difficult because it's a tumor in the brain, and the brain does a lot for our bodies, correct? So there's usually a lot of symptoms that go along with having a brain tumor. And then on top of that, she was young. Young meaning like 30s, 40s. That also adds to things usually. So this woman came onto service. She had a lot of symptoms. She was young. She didn't have a lot of help, and she was refusing all Western medicine. Now, again, we will always respect what people want, but did that make her death more difficult? Absolutely, because her symptoms were not managed, and they were not managed because she was refusing all Western meds. So she was still taking things like vitamins and different creams, different lotions. She was taking cannabis products, which are all great and can help to an extent. But when you are in the dying process with a brain tumor, you usually do need a lot of medications to help with those symptoms. Since she was refusing those, it made her death very hard. She had seizures, she had confusion, she had pain, she had shortness of breath, she had everything you can think of, really. And because she was refusing medication, those things weren't managed. So she did have a more difficult death, which is very, very hard to watch, and it was really unnecessary. So here are the 5 symptoms that can make death harder, but here are the solutions that can help. So the first symptom, and the most common one that people think of when they think of death, is pain. Number 1, pain. Now, let me be clear. Not everyone dying will have pain. Period. End of story. In fact, many people don't have pain when they're dying. Death is not painful. It's the diseases that you die from that can be. So the first symptom that is a very common symptom but doesn't always happen is pain. Now, what usually causes this? A lot of cancers can cause pain. So if you think of cancer, not all cancers do, but many cancers can cause pain. Certain tumors, if you have, can cause pain depending on where they are. Some people don't have pain because of what they're dying from, but they have pain because they have rheumatoid arthritis, or they have always had like chronic back pain, right? So it's not necessarily because of the disease, but they've always had chronic pain, so now they're having pain during their dying process. But great news, hospice is great at managing pain. The hard part about pain though, let's just talk about if it's not typical, right? So typically someone has pain, we give something like Norco or a little bit of morphine and it helps. But sometimes if you have something that causes a lot of pain, or it's been chronic and it's been long, you've had pain for a long time, you may have pain starting here, and then we don't get it fixed or get it under control until here. And let's say here is a couple days since this initial start of the pain. In between that time is when it's really, really hard, right? Because when you're in a lot of pain, you think it's never going to end. This is always how it's going to be. It's so hard not to get into a headspace of this is never going to work. Especially if you are trying a bunch of things between here and here, you're trying a bunch of things and nothing's really working until finally something does, or until finally all the medicine kicks in and you finally are out of pain. So there still is some amount of suffering, even on hospice sometimes, because sometimes it takes time to get the symptoms controlled. And believe me, I do relate because I do have chronic pain from my neck and my head. I get migraines, and sometimes when you're in it, you can't see the forest from the trees, right? When you're in it, you can't see that there's going to be an end. So that is when it can be really, really hard. But hospice will do everything they possibly can to get you here where that pain is managed. And then throughout your disease process, while you're in this time when your body is shutting down, we may have to change it again because maybe now it's managed and it'll be managed now for weeks, and then suddenly, boom, pain crisis. It's not working anymore, right? And now you're in pain again. So then from when you start that pain crisis again until here when it's managed again, after we up some meds, change things around, you may be uncomfortable there for a few days again, right? So all of that is hard, but it is manageable, and I like to educate about it so people have a better understanding of what it might look like. Number 2, is nausea and vomiting. So I honestly don't see nausea and vomiting a lot on hospice. Not many people will have this consistent nausea and vomiting. But when you do, it is difficult. And who usually has this? Anyone with any kind of abdominal issue. So if you have tumors in your colon or your small intestine or your large intestine, or if you have some kind of like ovarian cancer and you have tumors in your pelvis, anything that can be like blocking your bowels from working correctly, or anything that can be blocking your stomach, can give you persistent nausea and vomiting. And that can be really hard. Now, like I said, good news. We are experts in this. We see this a lot. We see it enough that we know how to manage it, but it can take some time. So a lot of times we will give rectal medications because taking anything by mouth will make it worse. So a rectal medication for nausea and vomiting can clear it right up sometimes. Sometimes we have to try different anti-nausea medications, or sometimes have the pharmacy make up a combination of medications to give rectally. Sometimes steroids will really help because that helps with the inflammation, and that can help with pain and with the feeling of nausea and vomiting. Last but not least, and something we don't like to do, but it really usually will work, is giving someone an NG tube. An NG tube is a tube that goes up your nose and down into your stomach. And then we put it onto suction, and then that basically compresses your stomach and it takes away that feeling of nausea and that need to vomit. Now, that's not ideal because hospice is about a quality of life, and that thing going into your nose down to your stomach is not comfortable. Then having it in there is not that comfortable. Being placed on suction kind of keeps you tied to the suction machine. So it's all not comfortable, but it's better than feeling nauseous and being sick all the time. So that is something we also can do on hospice, and we will do if needed, because at the end of the day, your comfort is most important. It also will take time. Usually, like I said, you start here, you're uncomfortable, and then hopefully in a day or so, we get you to that comfortable place. But that in-between time can be really, really tough. Number 3 is agitation or restlessness. This can happen specifically with patients with cognitive issues, so like Parkinson's disease, Alzheimer's, dementia, people that have any disease that has to do with the liver can make you confused, agitated, restless. Sometimes your kidneys can do that as well. If they're not clearing well enough, you may get confused and restless. So we see it more often in the diseases I just mentioned, but also sometimes people just have that kind of personality. Like if they're used to being really, really independent and now they're kind of out of it and they can't do much, they might be a little more restless as well because they're not used to sitting around. They're not used to having other people take care of them. So that can also be an issue. And it's really, really hard to manage, specifically for the family, because this person is usually not strong enough to be trying to get out of bed or to be walking or to be doing whatever it is that they're trying to do. Usually the restlessness comes from them just constantly trying to get up, but they're not cognitively there. So you can't really talk them out of trying to get up. You know, the family member has to sit next to the bed and go, you can't get up, you're too weak, you can't get up. But the person doesn't listen to them, right? So the family members aren't getting sleep, the patient's not getting sleep, and it just causes so much turmoil. It's so hard. It's so exhausting. There is stuff we can do, right? So there is stuff we can do. It's a matter of how quickly it works and then how often we need to adjust medications. So sometimes we give the standard medication. We'll give Haldol, and the Haldol will work. The person will calm down and easy peasy. Sometimes we have to increase the Haldol and keep increasing it, or add another drug to help them kind of clear their brain a little bit. If it's because of the liver, sometimes we have to try to get them to take lactulose because they're confused because ammonia levels are rising. If you drink lactulose, the ammonia level binds to your bowel movements and then you poop it out, and that kind of makes you a little more clear. So there's things we can do to help with this. Again, it just takes time. So the time when you start to the time when it's controlled, that's where it's really hard for the patient, for you, for the healthcare workers, for everybody. Sometimes with terminal agitation or just regular agitation or restlessness, sometimes it is a matter of giving people high doses to sedate them until they eventually kind of wake up and seem and act a little clearer. Sometimes that works. You have to kind of hit them really hard with a lot of medication. They basically sleep for a couple days, and when they wake up, they're a little more clear. Sometimes we find that they're either asleep and okay or awake and not. So we have to weigh the risk versus benefit. And the risk is we can't really keep them awake, because if we do, they're going to be uncomfortable and unsafe. So we have to sedate so we can keep them comfortable and safe. And that is one of the difficult parts of end of life, because you don't want to just sedate your loved one. But at the end of the day, it's about comfort and keeping them safe, so you have to. So that is a difficult part that we do see sometimes, not all the time. I just think it's important that people know that can happen, and we manage it, but it usually means that they are asleep. Number 4 is shortness of breath. Now, a lot of people at the end of life will feel a little bit of air hunger. Their oxygen usually isn't low, and a little bit of morphine can take away that feeling of air hunger. So I'm not talking about that. I'm talking about when someone usually has some kind of lung disease, lung cancer, COPD, emphysema, where they have had shortness of breath for possibly years. You know, they live on oxygen, they feel short of breath even with speech. That can be difficult, and that does come with those diseases a lot of times. Now, we can definitely manage it on hospice. There's so many things we can do. We give steroids because that helps with inflammation. We give them oxygen, we give them morphine, and those things will help them not feel short of breath. But they still will be pretty sedated, and they will be debilitated, meaning it's going to be too difficult for them to get up and go to the bathroom. You know, they can, but they'll be really short of breath because it's really hard for them to exert any kind of energy. So again, we can control this, but it can be difficult because they don't have a good quality of life, because they have to not do much, and they have to be on a lot of medications to maintain them feeling like they can breathe okay. Diseases like that also have exacerbations, even on hospice, where like they'll be doing good on their normal meds, and then suddenly, boom, they feel extra short of breath even though they've done everything they normally do. And a lot of times that just shows that the disease is probably progressing, so we have to add more medications onto that so they don't feel so bad, right? And then they might crawl back up a little bit and have another great couple weeks, and then boom, have something happen again. So again, it's very, very normal, but it's hard. It's hard, and we will always get to a place where they feel better again. But again, the time when they start feeling bad till the time they feel better again can be a little scary and hard to handle. Last but not least, seizures. Now, I honestly don't see that many people on hospice having seizures, but the ones that do are usually patients that have some kind of brain tumors. Brain tumors can cause seizures. We usually keep people on anti-seizure medications for as long as we can. Eventually, they won't be able to swallow, so it'll be hard to keep them on those medications. So then we provide suppositories that can help if someone does have seizures. We are equipped to manage them, but sometimes people will still have seizures here and there, and that can just feel scary. That can just feel scary. I think normalizing the fact that that can happen, educating the family, them understanding they can call us and that there is a solution, usually via suppositories, but it still can feel scary when it happens. This video is not meant to scare you, it's just meant to educate you. I feel like I do most of my videos about how peaceful death can be, and that is true. But there are sides of it that can feel really, really scary, and I want to make sure people who have experienced that feel validated, and that you guys know there are hard parts to death and dying sometimes. The good news is with hospice there and you prepared, it can make it just a little bit easier.